in this wonderful CME for the Golden Jubilee celebration of the Andhra Pradesh Orthopaedic Association is by none else but the well-known orthopedic surgeon from Khammam, Dr. P.N.V.S.V Prasad, who is known for his outstanding contributions not only to the field of Viludarav, but also to many other intricate and tricky problems in orthopedics, and his extremely helpful attitude to the young surgeons. Here, he will be sharing with us 30 years of his experience and the unusual things that he has invented, designed, and discovered. I hand over the podium to Dr. P.N.V.S.V Prasad of Khammam. Dr. Prasad, share your screen and start it off. Thank you.
Thank you, sir. Thank you very much for the very beautiful introduction. And I thank the organizers for giving me this opportunity of giving a talk on this occasion of Golden Jubilee celebrations of Orthopedic Surgeons Association of Andhra Pradesh. Can you see the?
Everything is clear. Beautiful. Please go ahead.
Okay. Okay. I'm going to give a talk on Jugaads in orthopedics. These are the days of internal fixations. Because of certain factors, the non-indications have become relative indications, and relative indications of surgery have become definitive indications. And sometimes even non-indications have jumped to definitive indications because of this change has happened because of many factors. Some of them are patient related, many are technology related, some others are surgery related, and can be due to the following reasons. We are struggling with the advanced technology and committing many mistakes. The surgeon factors could be non-availability of the specific implant on the table because of many factors, like the supplier might have supplied a different implant because of a communication gap. The OT staff might have kept ready a different set of instruments ready for the and implants for the surgery, or a mistaken decision making and omissions and commissions by the surgeons and wrong positioning of the implant because of the lack of skill and training. Even with all the above problems, we are managing because of our patient's tolerance, as this patient walks into the OP with a simple stick and for some other problem rather than her malunion of the condylar fracture of the femur. The surgeon's factors could be the mistaken identity, mistaken decision making. When a upper third fracture humerus have come up to him, he might have taken a decision to put an interlock nail from above, or he might have done a plating of the humerus, but he opted for a retrograde nailing of the humerus, during which he has splintered the posterior cortex and then a short nail into the proximal segment, which caused a devastation and ended up in a problem. Something like that, intercondylar supracondylar fracture might have been fixed with a LCP, which is gold standard, but he opted for a screw fixations and then cancel screw fixation and a supracondylar nail, which has not introduced fully, or it might have slid down and it is in the knee joint, which with a lot of problem of knee stiffness and all associated problems. And another case of extracapsular neck of femur along with comminuted fracture middle third shaft which might have been well fixed with an reconstruction nail or a long PFN. But he has opted for a DHS at the upper end and a very long plate at the middle third, which he could not fix it properly and ended up with problem. And he has opened almost 1 feet of his femur. Totally, you can see the scale and long incision and lot of trauma to the soft tissue. You should respect the soft tissues and do the surgeries. Minimally invasive days have come up long before, but still people are doing like this. It is because of lack of proper training. And people are doing a PFN without screws, either at the upper end or at the lower end, or sometimes they are doing surgeries without the screws at the site of that is needed. That is the lower end here. It requires a requires screw fixation, but he has done an upper end locking, but not the lower end. And wrong positioning of the implant. You can see a correct position could have prevented this recurvatum deformity of the supracondylar of the femur. By putting it in a correct way, you might have not landed up in recurvatum deformity. Another case of proximal third tibia fracture, which was fixed with interlock nail, but the nail was not introduced fully and there was no polar screws, and it ended up in a procurvatum deformity. And another case of supracondylar fracture or lower third, middle third junction fracture, which could have been fixed with a supracondylar nail rather than an interlock nail from above, and the centralization has not occurred, and so there is translation. And another case of upper third tibial condylar fracture, upper third tibia fracture, and both the implants, the screw and the K-wire, are in the proximal segment, but not in the distal segment. I don't know why they have done the surgery thinking that they are holding the proximal to distal. Another case of medial malleus, which was minimally displaced or undisplaced, which was fixed, tried to fix with a malleolar screw, but the screw is seen outside as a what you can say as just compressing the fracture, something like that. It is seen under the soft tissue. Another case of lower third of the tibia, the target has been missed and no screws were put into the nail. Only one screw has been used and a short nail has been used. In this case, it could have been a little longer. And another case of similar this thing, the nail, interlock nail was used. For doing an interlock nail, the surgeon has opened up the whole femur, almost 25 centimeters long incision, and finally he could not lock the proximal screws, neither the proximal nor the distal screws, and ended up with a sinus and infection, and it's disaster. Another case of external fixation femur, the surgeon doesn't know how to pass even a Schanz pin, and he has crossed the threaded part out of the distal far cortex, and it is fixing only with a non-threaded part in both cortices. Another case here, he tried to do the lengthening of the femur in a child where he could not. This fixator is not sufficient, and ended up in a further deformity of the limb. And instrumentation problems are like jig might not be matching because of previous surgeons hammering, using a non-cannulated bolt in place of cannulated bolt, faulty dynamic holes, faulty designing of the implant. There is no standardization of these implants in India, and so they come with different types of problems to us, and we will be ending up in trouble. So the proximal lock has been locked in the supracondylar nail, but the two screws are missing the target. That means the previous surgeon might have hammered on the jig rather than on the hammering point. So there is a bend in that jig, and finally it has become like that. And another case of tibia interlock nail, the same problem. We don't bother for the next surgeon who is doing this. next surgery. So we do whatever we like on the table, and then we make the other surgeons suffer like this. So don't do that in future. If you have a problem, inform the implant manufacturer and tell him that such and such and thing has happened, and change the jig so that the other surgeon will not be in trouble. And this bolt looks like a cannulated bolt, but when we have put it into the humerus nail and pushed it, it was not going. And then when I have checked in the CM, the guide wire is like an alpha. It is bent into twisted. And when I have checked this, this came to my notice that the locking bolt is not cannulated. So such things can happen, and be aware. And can you make out any difference in this? Now you will know what is the real thing. This should look like this rather than like that. I don't know why the manufacturer has come up like that. I've seen it somewhere and I could not understand what it is like and what is meant for. So like that, you should be able to identify your instruments and your implants, how they are being manufactured or sent to you. Can you make out any difference in this customer process? You can see the next. The size of the calcar part is more in the first one, a bit less in the next one, and normal. This is the normal one with a less collar. If you put it the head tip to the collar distance for the same size of the implant, for the same 43 size, it is longer in this and shorter in this. And once you try to insert the first one into the acetabulum, then the calcar will break up and because of the muscle tightness, and you will end up in lot of problem. So identify what is wrong in this, and then only you insert the implant. Can you make out any difference in this? This is marked as 135 4-hole DHS plate, barrel plate, and the next one is also marked with same 135 degrees, and you can see some angle difference. When I put them side by side, I could notice that the upper one is 135, the lower one is 120 degrees, 125 degrees. That means implant manufacturer makes something and sends to you, and you will end up in problems. You can see that when I started inserting that 125 into 135, this thing, it is not going. The tip of the plate is touching the bone already before entering into that. And next, I checked whether I am wrong or something like that, and I have inserted in a different position or something. Then my guide wire and the angle guide are just matching. And when I have put another plate into position, it has fit into perfectly. Another thing, you can see that the nail of PFN has been inserted much deeper inside to get these two screws into the head and neck, but still they are in the upper half. I wondered what happened. Then I have measured that the manufacturer has asked the worker to make it at 135 degrees, but there is a bend at the upper third for the PFN, and he has not considered that, and he has made 135 degrees to the upper part of the after bend, and so that has become 142 degrees instead of 135 degrees, and so the problem came like that. Somehow I managed to fix it, and I could get good union. And another case here, the next slide is the dynamic screw is towards the fracture. We expect that the dynamic screw should be away from the fracture in an interlock nail, but when the static lock is in situ, it should be at the upper part or away from the fracture, but it has not been like that, and these are the implant problems. And the next one, this jig, you can see that he has made it in the center rather than this side or that side. He has taken a via media approach, and the next one here is also, it is also not away from the fracture, but nearer to the fracture in this PFN. Patient factors are like extremely narrow marrow cavity sometimes, severe bowing of the bones, small bones like in poliomyelitis, congenital abnormalities, fractures around amputation stumps. All the previously shown slides were some of the causes for searching alternatives during the process of the treatment. Here, the patient opted for non-operative technique. He doesn't want any incision. He doesn't want scar, nothing. We could have happily done an interlocking nail like this. But when the patient has opted for this, I have put 2 K-wires and casing, reasonably good alignment. And I have removed these 3 K-wires, and you can see good union and good correction, no deformity at all. So you can get away even when the patient doesn't want an interlock, you can get away with this type of treatment. Here, when the supracondylar nails were not introduced, I have selected a gamma nail. At that time, gamma nail was available. So I reversed the gamma nail and put it from distal part, and I could get good result and good union for a supracondylar fracture like this. So you can modify or you can use the available implants if you know the heart of your implant very well, how it behaves. Here is another case of a supracondylar nail that has been introduced from above because of the gross contamination at the lower end. I could not put a interlock nail, which is the minimum length is 32 centimeters for a femoral nail, and a shorter nail is not available. So I have not modified, I have inserted the supracondylar nail from above, a 25 nail, and then locked it. And finally, I could get good union. This is an amputation stump and grossly contaminated the lower end of the stump. Here is a case of poliomyelitis, fractured tibia. A humerus nail has been inserted and proper precautions were taken because the superior screw will go from anteroposterior rather than from medial to lateral. And so proper precautions were taken so that I will not cross the posterior cortex, and fixed with a 7-number interlock nail of the humerus. And I could achieve good union. Here is another case of congenital deformity with varus hips and valgus at the supracondylar area with a short stature of the patient. And I tried to do it with modified because that short length of nail is not available. So I have selected a RECON nail and modified it, shortened it, and put 2 screws at the distal, 2 holes at the distal end. And then I tried to insert that. But at the end of the hammering, the nail is not going inside. Then I checked under CM, and I found that the wide part of the nail is stuck at the isthmus of the femur, and so I could not go any further, but somehow managed to lock it into the neck with 1 screw and 2 screws at the distal end. A valgus osteotomy done at the upper third and a varus osteotomy at the lower third, which has been fixed, and I could get good union and good correction. So while planning the modification of the nails also, you have to take into consideration the length of the wide portion. And here you can see the RECON nail is long, wide part at the upper part, and PFN is having less length at the upper part. So you have to take into these considerations while modifying the nails. And you can see difference between this RECON and then the PFN. And finally, at the end, after that surgery, he has done a lengthening. We have done a lengthening of almost about 12 centimeters at the tibia, and we could get a good correction. This is the first image which I have shown, and this is after correction, and good correction has been achieved. But we had done the tibial lengthening, femoral lengthening was not corrected. but deformity was corrected in the femur, and so his bum is little off the ground. Another case of achondroplasia of femur with neck shaft angle of 110 degrees in AP view and neck shaft angle of 135 degrees in lateral view. This with increased lumbar lordosis. These people will have more of FFD, and so they try to correct it, and that gives rise to increased lumbar lordosis. So an abduction and extension osteotomy has been done in this case at the subtroch level, and another corticotomy about 2 inches below that for lengthening. And a modified humerus nail has been used with additional holes at the upper third, middle third junction for transportation and fixation at the between the two corticotomy sites. And one side I have used a 7 number nail, which was broken, but 8 number nail sustained, but that had a problem of lag in distraction because it was a bit tight, and the angle has been corrected. Neck shaft angle has been corrected to 160 and then 130. And you can see that there is good distraction, but finally that nail has been broken at the modification site and good union. This is another case of poliomyelitis with osteotomy done before for hand to knee gait, and this has been corrected by using a modified humerus nail, and fixator assisted correction has been planned. And you can see I could fix with a humerus modified nail, and this is the final union and then the result. Here in upper end of the tibia, I prefer a supracondylar nail in place of UTN as it is cheap and having 2 cancellous screws for good hold of the cancellous bone. I usually fix it with supracondylar nail for upper third fractures of the tibia, and you can see good union and good hold of the nail of the proximal segment. And my entry point is lateral to the patellar tendon, not suprapatellar approach. This is lateral to the patellar tendon, and entry is anterolateral part of the tibial condyle, and guide wire is passed, and the nail is also passed. Here, the difference of cortex from here to the distance, this has to move posteriorly so that a polar K-wire has been applied this much. This is the polar K-wire, and nail is reinserted, nail removed, and then polar K-wire inserted, and then the nail repassed, and you can see good correction of the good position of the fragments, and it is simple tibial nail has been locked and the polar K-wire has been removed. Another case of tibial plateau fracture along with the upper half of the tibia fracture comminuted, and after reaching the OT, assistant says, sir, only left side is available, very long plate, but right side is not available. What to do at that time? So I have fixed the intercondylar area with one cancellous screw, and then the left side tibial nail, tibial plate has been put on the medial side of the tibia and fixed with the plate with good reduction, and you can insert this subcutaneously. The only precaution you have to take is that this is tilted, the plate is tilted because of the medial condyle tilted posteriorly, not straight. You have to take care the upper screws should not pass through the cortex on the posterolateral aspect and cause problem to the common peroneal or arterial problems. So that precaution you can take, and you can use this opposite side plate onto that. And another case of poliomyelitis, you can see in the upper part, this is the femoral condyle, normal femoral condyle. This is the patient femoral condyle with poliomyelitis, and the lateral condyle is little bit widened, and this type of widened femoral condyle, little tibial condyle will appear like this if it is reversed. So opposite side tibia plate has been taken and then fixed to the femoral condyle with the same shape without altering any shape of the plate that has been matched and then fixed to the femoral condyle. And I could achieve good result and good union. Another case of intercondylar fracture femur with supracondylar extension. Usually I fix with 2 cc screws at the posterior part of the intercondylar area and then take a entry at the little anterior to the angle of uh, cortical angle at this area and then insert the nail. So I could get good reduction and stability of the fracture. So you can treat even those fractures that can be treated with, should be treated with plating, can be treated if you take proper care and get away with this. This is the entry point. You can see another case. Here, surgery was done somewhere. He came with non-union at the supracondylar area with broken screws, and there is an anterior translation and valgus, which has been corrected by putting the nail in a reverse direction so that the posterior cortex of the distal fragment has been pushed by the nail, and then it could give good translation without much effort. You can see good. So take home message is, with judicious execution and knowledge about the size, shape, angle, and availability, many implants can be used at a different place than they were meant for. One should know the stability that the implant is giving at the other site and to immobilize the limb accordingly. When used in polio, the limb is of more in size compared to the bone quality, and the implant is meant for lower sized limb, and so the failure chances are more. So take precautions and do not promise the patient that he will be able to walk immediately after the surgery. Promise only that the best possible will be done, and it is the duty of the nature to heal. Ask them to take rest for better results, like in fever, where they give rest for early recovery. Know the heart of your instrumentation and the implant, like you know the reactions of your better half in different situations. You can get away even in situations like this if you are judicious about immobilizing the patient. Some person has applied simple L wires and could get away with that. Good union was achieved, and the subtroch fracture, which is dangerous for all of us, which has been treated well with simple cancellous or cortical screws and could get away with that. In situations like this, where he had he had wound at entry point and vertical split in the upper segment, which has been handled with interlocking ender's nails with 2 cc screws. The nails were inserted from below because the entry point at the upper end was not good, and so we could pass the nails from below, and they were interlocked like that, and good reduction has been achieved and good union. Thank you. Thank you very much.
Wonderful talk, Dr. Prasad. And I
Thank
think
you.
Dr. Prasad's talk properly and truly reflects the concept and theme of the conference today, that is retro to metro. He has combined both retro and metro, using metro techniques in retro situations and managing to get away with really substandard implants to produce outstanding results with direct idea and thought only about the patient's benefits. And I will just give a small summary of Dr. Prasad's talk. It is more important to understand both the biology and biomechanics and be a gardener in orthopedics than a carpenter. So with this message